Okay, thanks for joining us. Our patient is has just undergone a right sacroiliac joint Duke plasma rhizotomy by Dr. Patel. Next, we're going to be doing a Duke plasma rhizotomy of his facet joint because he has facet joint pain. All right. So I need to target the right L4 transverse process to get the right L4-5 facet joint. Every facet joint is innervated by these nerves that are called the medial branch of the dorsal ramus. And the nerves travel in a very specific location that is next to the transverse process, right where I'm aiming for. Shot. You guys see where the tip of that needle is? Show us, Jordan.
Yes, we do.
That needle tip is exactly the target. Now, the problem is the nerves that bring the pain signals from these joints, they don't read the textbooks and go exactly where they're supposed to. So they can actually be a little off of the ideal location, if that makes sense. They're never going to be exactly where they're supposed to be. They don't follow the textbook. How's blood pressure? Still good? Yeah. So instead of hoping that this treatment can get the nerve, we actually bring the treatment to the nerve. And oh, I like this. That's pretty awesome. This is like an OB-GYN tool, isn't it?
It's a sponge grabber.
Yeah, I see it used in like general surgery. Keep your hands away. Shot. All right. So I'm going to keep working here as we're talking and stay away. The target is basically right north of my probe. Shot. All right. So you see where the tip of my probe is? I'm trying to get it right exactly on the spot. Shot. And that's pretty much perfect right there. So that's L4. Everyone agrees?
Yep.
So that's where we want to do our rhizotomy. I want to, and I'm going to, the way I do it is I have a technique I use that we developed here at Duke Spine where we actually hop around on the transverse process. Shut. That's like literally the perfect spot, right? But I'm not just burning one spot, I'm burning various spots because I'm wanding my tool around to make sure I get that nerve, okay? Can you see this, Henry?
Yes, I do.
Or Sanjay? So
Yes.
I actually hop and I slide this way and this way, this way and this way, and up and down, three-dimensionally, to make sure we burn that nerve, okay? This is the most effective treatment in the world for this problem. There's only one other treatment that actually works that gives long-term relief, and that is fusion, spinal fusion with screws and rods, which nobody really wants, and nobody should have to have when this is available. Shot. Now I'm aiming for the next transverse process, which is, you can see it on the x-ray there, and I can feel it. It's very important you dock the tip of your probe on the bone. You can see it's right on the transverse process, and then you want to scoot medially until you basically rub up against what's called the superior facet. The superior facet. That's what's going to block you medially. But right at the junction of the TP and the superior facet, that's where you find the medial branch of the dorsal ramus, which is the nerve we're trying to destroy to get rid of his facet pain. Show us the arthritis in the facet joint there, Jordan. You guys see the arthritis there?
Yes, we do.
Look at the other side. You can see the other side even better. but your hand is in the way. Shoot again. All right, show the arthritis. You see that right there? That's an arthritic joint. Now look at the joint space itself. Show us the joint space. It's that little L shape like a hockey stick, right? And then look at the black on both sides, like the really dark color. That is very dense bone that comes from what we call sclerosis, which is a thickening of the bone. Okay, I don't need to do S1, but I'm going to do it anyway just to be sure, 100%. It's actually, yeah. When I say S1, I mean the sacrum. This is the last DPR. I'm right on the bone. And that should be good. So we're done with that. All right, we're finished with the Duke plasma rhizotomy to treat the pain from the facet joints and the SI joint. Next, we're going to move into the discs. And we're going to do L2-3, L3-4, correct? Everyone agree? Right side. Yeah, let's go to a lateral view. Put some pressure there. Keep it there. I need a rolled blue towel. This is what you should be using, not that. You put it here and hold it over the muscle and put pressure. Shot. All right, so we need to see the sacrum on the x-ray. We're going to use our x-ray machine to navigate. All right, there's L5-S1. There's 4-5-3-4-2-3. Okay, so I'm going to go ahead and navigate my needle. You can keep your hand there, keeping pressure. And I'm aiming for the L2-3 and the L3-4. Shot. All right. I'm going to give a little numbing medicine. And I really don't want to get rid of this instrument here. It's so cool. I haven't seen one since I did like general surgery. That's a sponge. All right, so 5, 4, 3, 2. So I'm a little higher than I want to be. I actually want to be right around here. Shot. Shot. Now, where is this patient from? Florida. Yeah. So I've done a lot of numbing medicine for him. I've injected the muscles. Now the first step in the disc repair is to go and place a needle. So 5, 4, 3, 2. Let's do 2. You want to do 2, 3 first? Is that what you want to do, Jordan? All right, so we're going to aim for 2, 3. All right, so 5, 4, 3, 2. We're a little bit low. I need to bring it up a little. Shot. There we go. It's much better. Now we're hitting the facet. I want to get around the facet. I may be hitting the transverse process. I think we're off on our WAG just a little bit, don't you think? What do you think there? I mean, it looks good. You can see straight down the disc space, but why do the pedicles look like they're out of line? Is that just scoliosis? Let me get an AP. I got to figure out if I'm up against the facet or the transverse process. It's TP. I'm hitting the TP. 5, 4, 3, 2. I need to be further north. Shot. All right, so 5, 4, 3, 2. I got this. Honestly, the hardest part of this entire surgery is just navigating the needle to the disc space. Once you've done that, the rest of the surgery just kind of, follows the guide wire. Shot. So, what's interesting is his spine is more anterior than you'd think. AP? He's not a big guy. He's in good shape for the most part. And I'm having to aim very anterior to get to the disc space, yeah. So we're hitting up against his facet. Go ahead and Back to a lateral. Let's go ahead and run our video showing the audience how does a disc cause back pain in the first place. And we're not fixing these discs for back. Shot. As you could see from the video,
Keep your head still.
don't move, you're doing great.
Just starting to wake up a little bit, getting a little
Shot.
itchy. Try to keep your head still.
He's wiggling around. As you can see from the video, the tear in the disc is what causes all the pain. Shot. That's a better trajectory for me. Shot. I'm still bumping up against the superior articular process. Shot. All right, I'm happy with that. I'm going to make my incision. I'm going to place my second needle and let him wake up a little bit.
Hey, my friend,
Lay still.
can you open your eyes for me?
Lay still.
Try not to move your arm, okay? All right? We're going to ask you some questions now.
Now that I have the incision marked, I can actually place the second needle. Don't move. Everything okay?
Yeah.
All right, Jordan. Let's open up that second disc. Let's get that into view. Shot. So the first needle is at 2-3. The second needle I'm aiming for is 3-4. Shot. I'm up against the facet once again. And Luis, I need you to back off on the pressure because it's shifting my needle position.
Keep your arm still, my friend. Okay, you're
Shot.
doing great.
Yeah, he's tightening up and it's shifting my needle. Shot. Shot. Just lay still. Shot. Shot. All right, so
I gotta have your arm still, okay? You gotta
let me
have-
know when he's awake. At this point, let's just take a look at the sacrum, make sure we're at the right level. We've now gotten very close to the discs. I mean, I need to see the needles too. Yeah, so sacrum 5, 4, 3,
Can you
2.
open your eyes for me?
I think we're at 2, 3, 3, 4. You agree?
Please don't move. Open your eyes.
All right, go ahead and line up the fluoro. We're at the right levels. Let's just get the fluoro in position and navigate. That's good. That's good. All right, that's perfect. Let me know when he's awake. Let's just shoot a quick AP. So I'm navigating these needles through the holes in the side of the spine on the right side. Let me know when you're ready.
How you doing, my friend? You all right? Okay, we're gonna ask you some questions. Keep your arm
Perfect.
still, okay? Keep your arm still.
Okay.
Arm still, going to ask you some questions.
You can see on that x-ray, Sanjay, the scoliosis, the twisting of the spine. We're not
Yes.
here to fix the scoliosis. We're here to fix the pinched nerves in his spine.
Got it.
All right. Is he ready? All right. Don't move. Lay still. Sean? Are you comfortable? Don't move your body.
Stay still. Keep your arms still.
We need you to lay still.
I'm going to ask you some questions.
Sean? What's the issue?
Where she ordered it? No, it's a question that Dr. Patel has about her patients.
Sean? You awake? You awake?
How you doing, my friend? You okay? Yeah, he said yes.
You having any pain?
You having any pain in your leg or your back? Where is it?
So I'm navigating through the frame and I'm going right underneath the nerve root, but I want to make sure I'm not too close to the nerve root. So that's why I need the patient to be awake to help me. He's the only person that can tell me if I am.
You okay? Do you have any pain in your legs?
Wake up, it's Dr. Duke here. Are you having any pain?
Are you having any pain? Where? What's that? Leg or back? What? Back, he says. He's having pain in his
That's what I figure. Shot. Lay still. Shot. Shot. That looks pretty damn good, huh? All right. We're ready to do a discogram. So folks, when I asked this patient, where do you have back pain? He told me, I'll show you, he has back pain here. This area right here. Can you guys see that?
Yes, we do.
He doesn't have back pain here. So what he has up here though is two giant herniations that are literally crushing the nerves going down his right leg. So his right leg symptoms are from pinched nerves at L2-3 and L3-4. This is L2-3 disc, and this is the L3-4 disc. You're okay. So basically his leg symptoms are from these two discs. His back symptoms are from his facets and his SI joint, which we've already treated. So now we've just got to finish this treatment by getting rid of these herniations that are in the lateral recess and the neural foramen. Are you comfy? Hey, wake up. Lay still. Are you comfortable? Is he on the CPAP? You having any pain? Huh?
Yeah, where's your pain? Lower. That's why I rather do the DPRs last.
That's fine.
You know, from now on, it's so much smooth.
Shot. How bad is that on a scale of 1 to 10?
8.
Is that where you get back pain? Fascinating. So 8 out of 10 for both L2-3 and L3-4, and it is concordant. It's interesting because when he showed me where his back pain was, it was here. But he's also having back pain here apparently, but that wasn't as important for him when he was telling me in the clinic. So once again, just for clarification, we're doing 2, 3, 3, 4 DLDR for pinched nerves, which cause leg symptoms, not back pain. But we are doing, it turns out they're also causing back pain. So it's a good thing we're doing them. Any questions from the audience?
No current questions.
No. Are you broadcasting?
Yes, we are.
All right. Just making sure. Shot. So I'm going to remove the needle, leaving the guide wire. Shot. You can see the front of the guide wire at the front of the disc there at 3-4. We've already made our incision, so I'm going to run the dilator down over the guide wire and shot. I'm keeping an eye on my my guide wire tip to make sure it doesn't advance into the abdomen. Shot. And you can see the dilator coming down. Shot. All right, we'll do a little num-num. So I'm going to give him some more numbing medicine because we're passing through the muscle and fascia just in back of the spine. And I'm advancing my dilator tip down, shot to L3-4. Remember, there's a giant herniation. You can actually see a clue to it right there with that little dye in the foramen. I just went past it. All right, now I've got to advance this dilator into the herniation. That's what I'm doing. So I'm pushing it into the annular tear and herniation. And to do that, I use a mallet. Oh man, he's got a huge tear. Pull that guide wire out. He's got a huge tear. Look at that. It went in so easy. So that's why he blew that disc out, because he has a massive tear in the back of his disc called an annular tear. And that's where the back pain comes from, by the way. Any questions?
No questions, but we do have a comment from Lioness Blessings,
Yeah.
and it says, yes, we are here, Doc.
All right, very good. Thank you. I just want to make sure we're streaming okay, so you all can see and hear. If you have questions, feel free to ask them. I like answering questions while I'm operating because it gives me something to do. All right, so I like to pull that back a little bit and see where the tip of the dilator is. Shot. Tip of the tube. Keep going. A little bit more. Shot. Shot. You see the tip of the tube? I think we need to go in just a little bit more. Shot? Yeah, that's good. All right, just a lot of dye there, so it's hard to see. Just take it out. Shot? Perfect. So for those of you wondering, we're now inside his herniation, okay? And I'm going to use my endoscope to look at the herniation and the tear where it came out of. And I'm going to use my laser to remove it. Remove the herniation and clean up the tear. Once the tear's clean up, his back pain will go away. Once the herniation's gone, his leg symptoms will go away. Now, for those of you wondering, this is not surgery done in a hospital. This is outpatient surgery. There's no reason to take these surgeries to the hospital because the hospital is for people who need really to be admitted and to stay in the hospital recovering from spine surgery. Hey, you hold that? Hold that? Hold the tube. Yep. Here comes a big-ass herniation. Look at that herniation right there. Come on, Nick, you got to pay attention. You can't let that go somewhere it's not supposed to go. Just keep an eye on her. All right. Any questions from the audience?
Yes, we have a question from Leslie Coles on Facebook.
All right, Leslie. Leslie, you said?
Yes.
That's
Does
a
it?
big piece of herniation right there. Oh, yeah, look at that. Check this out, Sand.
Yes, we can see that.
Good size herniation. Before we get to the question, can you see this?
Yes. Yes, I do.
All right. Good size herniation. That's about 2.5 centimeters. Huh? What do you mean deeper? Oh, a keeper. Yeah. Yeah, and I want to just make the point, which I've made many times before, folks. A herniated disc is not one piece of herniation. That's a very important misunderstanding. It's actually multiple pieces of herniation that occur over time, over even a lifetime. Some people have multiple herniations over 30 years, 40 years. We rarely see one herniation, just one chunk. It's usually 10, 15, 20, 30 pieces. You got to teach her how to grab that. Not grabbing it properly.
Just for reference, what's the size of the tube that you're sliding into?
Yeah, so before we get to our question from Leslie, the question came from the operating room is, what's the diameter or width of that tube? So that metal tube right there is around 5.5 millimeters. 5.5 millimeters. And the glass that you guys are seeing right there, that little glass electrode thing, that's where the laser energy comes out of. That is 1 millimeter wide, 1 millimeter. So that gives you an idea of just how precise this surgery is. We're working at millimeter, actually sub-millimeter levels of precision with the laser. Okay, the laser is the most precise tool in surgery. There is no tool more precise. And yet the reason spine surgeons talk badly about it is because they don't know how to do the surgery. So they don't want to lose their patients and their business to other surgeons like me that do laser surgery. The reality is that these surgeons should be trained on laser surgery so that they understand the value of it for their patients. It's a much better surgery than open surgery. Any other questions, Dr. Davis?
No, that's, it's just hard for the audience, I think, to realize just how tiny that tube is.
Yeah, the tube is very tiny. Laser off. All right, let's have our questions.
Yes, so it's a question from Leslie on Facebook.
Yep.
She asks, does it make a difference doing rhizotomy before DLDR?
Does it make a difference if you do rhizotomy before DLDR?
Yes.
The answer is it does for my anesthesiologist. He likes the rhizotomies first. Oh, the other way around. I apologize. He likes the DLDR first. And that's how it was supposed to be, but Dr. Patel, you know, he's kind of a prima donna. And he just showed up and said, move out of my way, I'm doing my part first. I'm just kidding. We love Dr. Patel, we all work well together. But Dr. Patel needed to do the rhizotomy because we were a little behind in schedule first, so we did it first. But normally we like to do the Duke laser disc repair first. For me, I don't have a preference. You know, I just want my anesthesiologist to be happy. That's all that matters to me. Because if my anesthesiologist is happy, he keeps my patients happy. And he keeps my blood pressure in a nice range. Luis, I don't know why we continue to have issues with, do you think this is the lens stuff? You see it's almost like it just gets, I don't know. I don't know, it just gets a little blurry. Maybe it's okay. It just may be a little overexposed. All right. So here's another piece of herniation. So we've taken out probably 10 of those pieces already. And the reason those herniations are now at the tip of the tube is when we put the dilator in, it literally shoves the herniation back into the disc, which is really quite wonderful because you're now removing the herniation, which used to be up against the nerve root. You're now removing it from the disc, which is a safer place to work than the nerve root. That was taught to me by my mentor, Dr. Anthony Young. Dr. Young was a big proponent of that technique. It's called the inside-out technique is what he called it. And it was his way of doing this type of surgery, endoscopic surgery, in the lumbar spine in a way that he felt was safer for the patient. So he would start inside the disc with his surgery, just like I do. I learned it from him. Whereas a lot of other endoscopic surgeons at the time, this was 17, 18 years ago when I was trained, those endoscopic surgeons did what's called the outside-in technique where they start outside. And a lot of endoscopic surgeons today start outside of the disc, herniation, which I think is more risky, and it requires that they actually damage the spine to get there to fix the disc. They do an intralaminar approach or translaminar. All right, keep the questions coming. You guys are doing great.
We have a question from Linus Blessings on YouTube.
Linus Lessons?
Yes.
Sure.
I will send you my MRI. I have a cyst under my SI herniation. In my case, would you fix my cyst too?
That's a great question. It depends on what kind of cyst you have. If you have an arachnoid cyst or a Tarlov cyst, we don't fix those. There's no need to fix them. If you have a synovial cyst coming from the facet joint and it's pinching your nerve, then you need to have that fixed. You cannot let go of that, okay? It's not acceptable. You have to have some discipline of your body. Okay? So the answer is, I wouldn't say yes or no. It just depends on what kind of cyst you have and where it's located as to whether or not it even needs treatment. I don't do surgery that's not necessary. And most cysts don't need treatment because they're not the type of cyst that cause problems, or they're not big enough to cause problems. But if your cyst is needing of treatment, I can tell based on doing an MRI review, and I could tell you whether or not I could take it out endoscopically. What's the problem, guys? What's the issue? All right, we're getting close to being done with this disc. You can see the epidural space at 12 o'clock, and you can see some epidural fat. On the right side, you can see the end plate of the vertebral body, the inferior end plate of L2. That's what the pink thing is there. There's still a little bit of herniation here, which I'm working on. Keep the questions coming.
Copy that.
If there's no questions, Sanjay, you want to run our video on how the Duke laser disc repair works? I don't buy side firing lasers. First of all, they're far less efficient, so they move slower. They do a lot less work in the amount of time. The straight firing delivers the most energy directly to the disc herniation. And you know, I've been doing it with straight firing laser now for 17 years with great results. So the question is, I've never lacked. You know what I mean? I've never gone like, oh, I wish I had done more. You know, not once. So there's an old saying, if it ain't broke, don't fix it, right? Now, you know, the Koreans used to do some laser work on their discs, and they would use a side firing laser. And it's great for, well, obviously getting to things like that are on the side, which is a great tool to have. We actually have side firing lasers here. I just don't use them. Exactly. That is one of the limitations of the side firing laser, is you can't really see what it's hitting. I mean, there's a little mark on it that shows you where the laser energy is being discharged from, but it's not 100% accurate. And you could end up, you know, just because of vision, you could end up zapping something you don't want to zap. Whereas with the straight, you're always seeing straight. Now this is a 20-degree up scope, so I can actually, yeah, it's not a straight scope. All right, any other questions?
We have a question from Lioness Blessings on YouTube.
Sure.
Great, thanks for the advice. Does United and Medicare insurance cover this operation?
Medicare insurance will not cover this operation. Not yet. Someday perhaps it will. Medicare will not pay for this surgery. United, it depends on what kind of plan you have. If you have a United Medicare plan, I would not count on it. But if you have a United plan that has not Medicare, then it could. All right, just about done. You could see the epidural space there, a little bit of fat and veins. You see Batson's plexus. This is a ligament within the foramen, just behind the disc, called the foraminal ligament. And I've gotten rid of the herniation. It's not there anymore. Just a little bit of scar tissue. You could see the end plates there and over there. And the nerve root will be right there. You guys see the nerve root, that white thing?
Yes, we
Okay.
do.
And this is just a little bit of herniation below the nerve root. Pretty cool. Now, any other spine surgeon that does spine surgery, they'll never see this view. That's literally the nerve root, that white thing right there, okay? That's going to be the L2 nerve root. We're done. Looks good. Very happy with that. Scope off. So I'm going to irrigate with a little bit of betadine, which is a really good product. We used to use bacitracin until the FDA made it so that doctors were uncomfortable using it. I guess some doctors were injecting it into the muscle, and you cannot do that. Okay? I'm going to pull it like this. You can't have your hand there. You have to hand it off in such a way that you move your hand out of the way. Okay? You have to learn my patterns of movement. I'm just telling you, you can't do that. All right. Yeah, the FDA mentioned that bacitracin was causing some nerve damage and muscle damage because doctors were injecting it into the muscle, which they shouldn't be. And basically the FDA made it very hard to get a hold of. But that's what I grew up on using. You probably did too, Davis.
Oh, yeah.
Yeah, Bassi, polymyxin and bacitracin, move out behind you. All of our surgical irrigation used to be a bacitracin and polymyxin mixture in saline. And that was for, God, probably 50 years. Good job. So now we have to use betadine. All right, we've just completed, I'm sorry, that was L3-4, so that would have been the L3 nerve root you saw, not the L2. Now we're going to do L2-3. So I place my guide wire. I'm taking my needle out. And now I'm going to use the guide wire to direct this tool, which is called the dilator because it spreads apart tissue. Everything okay, guys?
Yeah.
How's our patient?
Fantastic.
Wonderful. It's so good to hear. I didn't make my skin incision very good. Knife. I think I left a little tag of skin.
Right, take please.
That should do it. Shot. So these surgeries are relatively bloodless. If we were doing open back surgery, we would lose a lot more blood, about 1,000 times more blood. We're going to lose in this surgery about 3 cc's, which is 3 times 20 drops per cc is about 60 drops of blood. It's very little. If we were doing an open surgery, you'd lose 300. So maybe 100 times more in this case. But normally we lose less than 1 cc. He just happens to be a little juicier than normal. And some people bleed more for various reasons. Sometimes they're on a drug or a supplement that makes their blood thinner, so they tend to bleed more. Watch the scope. Shot. All right. Any questions from our audience?
No current questions.
All right, we are now inside the L2-3 disc, which is our second disc we're fixing. We're inside the tear and actually inside the disc. So I'm going to bring my tube down, and I want to advance the tube right over this dilator. And then once we get this tube in position, which is right there, then we can take the dilator out, and now I have a working channel, a channel that I can work through. You can see that on the x-ray. Perfect. Good job, everybody. We got probably 10, 15 minutes max. So as soon as I'm done, we're going to have to put some steri strips on these incisions, and our patient will go to recovery for about an hour, and then he's going home. When I say home, I mean the hotel, because almost all of our patients these days are from other countries or other cities. Hey guys, I need the, yeah, thank you, Jordan. All right, any questions?
No questions.
All right, have we showed our videos?
Yes, we have.
Both?
Yes, both of them.
Sanjay, you are the man. So what do we talk about then?
How's the patient doing?
Patient's doing great. Their vitals are stable. They're ventilating quite well. Oh, this is a big herniation. It is literally pulling against the tube. It doesn't want to come out. Oh. Yeah, smack that ass and give me an APCAR score. Look at that thing. That is big. That was a pretty good sized chunk. Yep. Yeah, it was firm. There's more coming, smaller pieces. Very good. Well, we have one more surgery today, I think, correct? Yeah. And our last guy is doing great, by the way. The one we did all the DPRs on, thoracic. He said when he came out, he couldn't feel any pain at all. So, yeah. He said normally it's there all the time. So. The patient that we didn't broadcast for you all because he was in room 2, which we don't have our recording equipment and broadcasting equipment, he actually is a sheriff's officer. And if you ever are on the highway driving and speeding and you see a little sign that has a picture of an airplane, it says speed monitored by aircraft. That was his job. He would fly overhead and he would sight you while you're driving. Nice man, but got hurt with some turbulence actually in the aircraft. Thank you. All right. We have a lot of police officers, sheriff officers that come to Duke Spine, a lot of military, because they don't want to have the traditional back surgery. They don't want their backs opened up. They don't want their lamina removed. They don't want their facet joints messed with. They want natural surgery that doesn't require metal or implants, that works. They can get back to their job quickly. So we have quite a few law officers, which I personally like law officers a lot. I was just talking to my wife about how we need more law officers in this country. You know, no point in having laws if people don't follow them. I guess some people think following the law is optional. I disagree.
We have a question from Alison Cameroon on YouTube.
All right, Allison Cameroon on YouTube. Thanks for asking a question. Feel free to go ahead and ask.
If you fix the bulge but still have instability, what are the chances of reherniation?
That's a great question. So a lot of people don't really understand what instability is, and people are told something that's not true. Instability, there's two types of instability. There's instability that is defined first by two orthopedic surgeons named White and Punjabi. This was about 40 years ago. Dr. White and Dr. Punjabi defined spinal instability as severe pain or neurological deficit that occurs when the patient is basically under normal physiological loads. What that means is they're just doing normal things that you would do during the day. Getting out of bed, going to the bathroom, showering, and the patient has severe pain or neurological deficit. What that means is the nerves are getting pinched, and the patient's getting pain down their leg or their arm. They're getting weakness in their leg from it. So that's instability, okay? This surgery cures instability. This surgery cures the pain. It cures the neurological deficit. So this surgery fixes instability. There's another type of instability that comes about from like what's called fractures, dislocations, or tumors, infections that eat your spine away. And they can create instability as well. And that type of instability does require reconstruction and instrumentation to stabilize the spine, along with fusion, okay? But it's very rare for those conditions to occur. The vast majority of what we're calling instability today is really just fixed by the Duke laser disc repair and does not need instrumentation, does not need fusion or artificial discs. I don't know if that clears it up. In other words, the true definition of instability for the masses is that definition of White and Punjabi. People have tried to redefine instability and create their own definitions, but instability is severe pain or neurological deficit with normal physiological loads. And this surgery fixes that. So.
We have a follow-up question from Alison on YouTube.
Sure. 5 minutes.
I just had a motion x-ray. It shows that the facet is slipping into my foramen, so it's pinching my arm nerve.
Pitching the what?
Pinching my arm nerve.
Arm nerve, okay. Yeah, that's really not what's happening, but that's okay. Somebody has convinced you of that. Well, my recommendation, if you want an honest diagnosis, is to submit your MRI. Let me review it, and I'll tell you why you're having your symptoms. But motion x-rays are very common among chiropractors. Chiropractors order them so they can show you something moving, so that they can get you to keep paying them money to go there every 3 times a week to get treatment. That's never going to work for you. That's typically when I hear motion x-rays. Unless you have flexion extension x-rays, which are standard types of x-rays, But that said, I don't think it's your motion that's pinching the nerve. I would be very surprised. Most likely you have a herniated disc or a bulging disc and spinal stenosis. That's the cause. The other possible causes include a pinched nerve in your arm, which case, if you got a nerve test done, that would sort that out. So when we're not sure where the pinched nerve is, we'll get nerve tests done. Even if we want to know how much nerve damage there is, we get a nerve test done. Nerve test is very good for assessing the amount of damage there is. Did you guys refracture this laser tip? Don't let your hand hit my hand. Okay? Did you guys refracture this tip? Because it's distributing the energy in a very unusual way.
We have a follow-up question from Allison.
Sure.
Does this surgery fix the facet that slips into the foramen, or would prolotherapy be a better option? I have also got disc bulging at the same level.
Yeah, your disc bulging is their problem, not your facet. This surgery fixes facet pain. This surgery fixes neck pain from a herniated disc or a bulging disc. There is really nothing that happens in the spine other than fractures, tumors, or infection that this surgery cannot fix. There's no mystery, no black box, nothing surprising or unusual. You have to be careful where you get your information from. There's a lot of people out there that want you to believe things that aren't true, and to sell you something that you don't need, that's not going to fix your problem. Come on, get it.
We have a reply from Allison on YouTube.
Sure.
She says her EMG came back clean.
Ah, good. So if your EMG is clean, that means you don't have a pinched nerve likely in your arm. So it must be coming from your neck, most likely. Just remember, though, that EMGs are subject to interpretation by the doctor. And the EMG is done with a computer. The computer has thresholds that are set by the doctor. Every doctor does EMG different. And where one doctor may set thresholds at one amount, another doctor may set different thresholds. The other problem with the EMG is that sometimes the nerve damage, if it's less than 20% nerve damage, it will be missed by the EMG. So let's assume for a moment that you don't have any nerve damage in your arm, but it's coming from your neck. Then my opinion is that it's the herniation, not the facet, that's your problem. That's what I would tell you based on 100,000 patients I've seen. Now, could it be the facet? Yes, but it would be the first time I've seen that in my career. So I still allow for the possibility that it's facet that's causing your symptoms, but I would just tell you it's extremely unlikely. Doesn't mean it's not possible. It is possible, but it's just very, very, very unlikely.
We have a follow-up comment from Allison on YouTube.
Sure.
What if a disc or bone spurring and bulge disc is causing some mild canal stenosis?
That was perfect. Yeah, if a disc bulge is causing stenosis, that's what would be pinching a nerve, causing arm symptoms.
Can you treat that with this?
Yes, that's exactly what this surgery fixes. Bulging discs, herniated disc, ruptured disc, protruded disc, slipped disc, migrated disc, prolapsed disc. Whatever name you have for it, it's the same thing. It's all herniated disc, basically. And this surgery fixes that. This is the best surgery in the world for that problem. The other kind of surgeries that would fix that would be a fusion called ACDF or an artificial disc. But the problem with artificial disc is they don't work that well and they have a lot of complications. I wouldn't do an artificial disc. I did many artificial discs years ago, but I stopped doing them because the results are not as good as fusion. And the companies that sell them, they just want to make money off you. They don't care about how you do. They don't have a patient. They're not doctors. They're companies. And a lot of surgeons, unfortunately, use the artificial disc as a way to market their company and themselves, but the results are not that good. Now, the reason I say this is very complicated, but if the surgeon is a very good surgeon, then the results the surgeon will get with fusion are going to be better. Stop handing me the other one. Okay? Now, if you're a very bad surgeon with fusion, then you can make your fusion results very bad. And then the patient should get an artificial disc. I'll give you an example. Let's say when I do fusion, I'm a bad surgeon, my fusion results are 50% complication. But then I do artificial disc, and my artificial disc complication is 25%. 25% is less than 50%. Therefore, that surgeon should be doing artificial disc, okay? Because they shouldn't be operating in the first place. But if they're going to do something, it should be artificial disc because the complication rate is much lower for them for artificial disc. But a good surgeon will have a fusion complication rate less than 5%. They'll have a artificial disc complication rate that is higher, around 10%, twice as much. Because artificial discs are just prone to having more complications. So I wouldn't recommend artificial disc for a good surgeon. I would recommend fusion if you had to choose one or the other. But the best surgery is neither. You don't want fusion and you don't want artificial disc. You want the natural way of getting fixed, which is this procedure you're watching, Duke laser disc repair.
We have a question from Teek on YouTube.
Hello Teek, welcome to our live stream.
How close is the hotel and airport?
No, I can't hear you, Sanjay. You got to enunciate and slow down.
How close is the hotel and airport to the surgery center?
How far is the airport from the surgery center?
And hotel to the surgery center.
Oh, the hotel is 5 minutes. The airport is 45 minutes. It's very close. And our new center in Orlando, the airport will be 20 minutes and the hotel will be in the parking lot. It's pretty crazy. Yeah, there's a beautiful new hotel being built in the same parking lot as our new facility in Orlando. It's a Hilton Garden Inn. It is gorgeous. I would stay there in a heartbeat. It's amazing. So it's going to be so cool. In Orlando, our patients will be able to check into a hotel and then walk across the parking lot to have their surgery. That will be next year, Christmas. If you want to wait. I don't recommend it, but if you do. All right, I need another minute and I'm done. There's just a lot of pieces of herniation on this disc. You can see all of them, little fragments. We call them fragments. Not figments, fragments. The other thing about the new center in Orlando is it's literally 10 minutes from Disney and 5 minutes from Universal Studios. So now there's the L2 nerve root right there. Let's get another laser. I want to get a little bit more of that. 30 seconds and we'll be done. Trying to just clean up the last bit of herniation here. Thank you. We're done. Good job, everybody. Now that hole that's there in the disc is about 3 millimeters. It's going to close on its own. The body is able to heal that as long as I get rid of the herniation, which we did. That hole is in the annulus. It's called an annular tear. Where's the suction, guys? The body is unable to heal an annular tear when there's herniation inside of it. Remember, the annular tear is not the herniation. The herniation is the disc material in the center of the disc that's spit out into the tear. All right, great job. If you have any more questions, type them up. I'll come answer them for you. Otherwise, this patient did really well. We got all the things we needed to get done. We lost about 3 cc's of blood, which is not much at all. If we had done open surgery, he would have lost 100 times more blood. And it's outpatient. He's going to go home in about an hour from now. All right, one more surgery to go. Our next patient is a truck driver. He puts in about 3,000 miles a week, he told me, driving his truck. And he's originally from Bulgaria. So he's a tough guy, but he's been having horrible back pain. And we're going to take care of that pain for him by fixing 2 bad discs. So if you have questions, type them up. I'll come answer them for you. Go ahead and take us to a testimonial there, Sanjay. Good morning, I'm Dr. Duke Majan at the Duke Spine Institute here in Melbourne, Florida, with one of my patients who traveled from California. He's been suffering with his lower back pain for years and found us on the internet and decided to come here and have the endoscopic Duke laser disc repair. We performed that 12 hours ago, and here you are, ready to go back to California, it looks like. How do you feel?
I feel great. It took a long time to get to you. Surgery was quick and painless. I don't remember a thing. Your staff was wonderful, but I am pain-free.
That's awesome. Yeah, and you're going to stay pain-free. We don't have you on any pain meds. We don't have you on narcotics, killing your pain. We didn't put any medicine in your back to stop your pain, so what you have is natural. And do you feel that pain anymore that you had before you came here?
No, the pain is completely gone. In fact, I quit taking my own pain pills 2 or 3 days before I got here. And I am on no pain pills at all, and I feel wonderful. When I woke up this morning, it was a different day, and I feel great.
And I feel wonderful for you for doing that. That's why we do what we do. We can cure pain, and we want everyone to know that, because nobody should have to live with pain every day. How does pain affect your life every day?
Pain is traumatic. The kind of back pain that I was suffering put me in bed. And for the last 3 months, I have been absolutely useless. Absolutely useless. And so I found you. It took me a few months to get here, and it was worth the trip.
It will be for the rest of your life.
Absolutely.
Worth the trip. Pain robs us of our dignity, doesn't it?
It does. It absolutely does.
And your parents are here, and they're very supportive. And that, to me, is so important, that you have people that understand what you're going through. I'm sure your parents have been a big support for you.
Oh, absolutely. Yeah, I was at work, a short story. I was at work last Wednesday dealing with this pain, and my back finally gave out to where I literally could not walk anymore. And I was 600 miles from home. And so I called my mother and father. They flew to San Diego and arranged the trip to get here. I called your place. I was scheduled for February 2nd, and I asked Richard on the phone if he could get me in sooner, because I was desperate. And you guys got me in a week or two sooner, got me in the 24th, which was yesterday. And so we made the arrangements, and I flew here, stayed in the hotel for a couple days, and was operated on yesterday. And yeah, it's well worth the trip. I apologize for getting emotional, but it's been a long trip to get here.
Well, we want you to get emotional, because it is an emotional thing. When you've been burdened with this pain for so long, and then suddenly it's gone, and you realize that life can be lived without that pain, you know, and that you can actually have a life without the pain.
Yeah.
So what are you going to do now that you don't have the back pain anymore?
Well, I'm going to get my life back together. I've got a new job, and they've saved it for me. My boss is wonderful, and I'm going to go back to work tomorrow, actually, if you can believe that.
Yeah.
And I'm going to start riding my bicycle again and getting healthy again.
Well, your surgery went very well. I don't know if you've watched it yet, but we were able to get in with a tiny 7mm quarter-inch incision and fix both painful discs, and they were both very painful for you. And the pain was coming from a small tear that's located in the back of your disc where your herniation came out of. And that tear was just so inflamed, and we were able to clean out the herniation that was stuck in your tear and use the laser to debride it. And that's what the Duke laser disc repair is. It's a debridement of the annular tear to eliminate back pain and leg symptoms. So we also have a cyst. We didn't treat your cyst. And do you think the cyst is causing any problems for you?
At this point, no. I don't think so, because all of my symptoms are gone. This morning when I woke up, I was a little nervous about getting out of bed. But that subsided quickly when I stood up and could stand up completely erect with no pain or bindage feeling in my back.
Yes, when I walked in and saw him this morning for the first time, the first thing your mother said was, "Look how straight he's standing." So they must have watched you suffer for a long time.
Oh yeah, yeah. Yeah, my mom's a great lady. I'm blessed to have her in my life. And then that's my stepfather, Jerry. He's a wonderful man. He and I are pilots. We fly together. We do a lot of things. And he's seen me go downhill. He knew something was wrong, you know.
How did you find out about us?
I've been seeing a chiropractor in Sacramento for 35 years. And 2 months ago, I started to really feel bad. And I would go to him. And after about a month of going to him and going to my doctor for some pain management for these symptoms, I finally figured out that something else was wrong with me. And so I asked the chiropractor, what can we do, because what you're doing is not helping me. My doctor put me on pain meds, and they took some of the sharp pain away, but nothing was helping. And so, being kind of a mechanical engineer, I decided to look into how my back was put together. And I requested an MRI from my doctor and from my chiropractor. And so that took 3 weeks to schedule. That's a long story. And I finally got an MRI, and I looked at it myself and realized that I had a cyst of some sort and that I had some problems with my lower discs. And that's when my chiropractor told me about you. He said, get on the internet and do some research and then call these people. So I called your store. They gave me some information. I FedExed my package to you guys, and a week later you called me. And about a week or two later, I got here.
Wonderful.
So, yeah.
And here you are pain-free for the first time in many years.
Many years, many years.
Congratulations.
Yeah. Thank you.
Is there anything you want to say to your fans out there?
There is. This is a miracle. In Sacramento, everybody that I know said, why are you going? Why are you going to Florida? Why don't you find somebody in Sacramento? And I said, well, because I was referred to Dr. Duke Majan, and I've done a bunch of research on him, and I just have a great feeling about him. Not only that, he personally called me on the telephone because I told his people that I had some questions. And that's what sealed the deal. And so it took a while to get here, but it was worth everything. And I would recommend anybody send your MRI to this guy, and if he can help you, he will. Okay? Thank you, Doc.
You're welcome, sir. It's my pleasure.
Yeah, absolutely.
All right, go enjoy the rest of your
All right,
life.
thank you.
All right, so let me straighten this out.
Perfect.
Okay, great. So we are just finishing with a pretty involved surgery that we just did. And for those of you who would like me to summarize what we did, take a look at this spine right here, okay? This is the pelvis, this is the iliac bone, and this is the sacrum right here. We actually had a patient, this patient had pain in his SI joint from inflammation in the SI joint. So clearly he had injured the sacroiliac joint in the past, had a lot of pain and inflammation. He also had pain coming from the facet joint, L4-5, L5-S1. So the SI joint, the facet joints, and then he had these two herniated discs way up here, L2-3, L3-4, that had such big herniation it was crushing the nerve going down his right leg. So he was having, you know, the back pain at the SI joint, the back pain at the facets, a little bit of back pain at the L2-3, L3-4, but then the nerves were getting pinched, they were going down his leg. So he was miserable. And really nice man. We just completed his surgery. We did everything in one surgery and it went very well. We lost 3 cc's of blood, which is not much blood at all. It's a very small amount. Had he had open back surgery, it would have been a lot more. So these surgeries are pretty much bloodless surgeries, no scar tissue except for the skin where he has a little cut, and no downtime. These patients are back on their feet the next day. You can go to work the next day. You can go to the beach. You can do pretty much most anything you want except no heavy physical activity and no carrying anything over 25 pounds for 6 weeks. I don't want my patients bending at the waist, so they have to limit their activities. But those limits are just for 1 year while the discs heal. After a year, they can do what they want. All right, we have some questions.
We have a question from Earth Body Official on YouTube.
Okay, Odd Body Official.
What do you know about chymopain, the papaya enzyme that's supposed to dissolve herniations, but isn't offered in the US?
Yeah, so chymopapain is an enzyme that's found in papaya that we used to use in spine surgery a long time ago, back in the 80s, 70s, 80s. And it was used by pain management doctors. They used to inject it into the disc, into the herniated disc. And there were some very good results with respect to pain relief from the injection. But what I know about chymopapain, I know secondhand. My professor told me about it, so I never had any firsthand experience myself. But the FDA took it off the list of approved drugs because there were some complications that were occurring. The complications had to do with something called myelitis. And myelitis is inflammation of the spinal cord, which is very bad. People were basically going paralyzed from the treatment. Now, because I don't have any firsthand experience with it, I can't tell you a lot about it, except that the doctor that I trust very much, Dr. Anthony Young, he said it worked great, and that the reason myelitis happened was that there were some surgeons that were using way too high concentration. They were just putting too much in, and they were trying to get better and better results. So they would add more of the chymopapain. And he said the levels that they were adding were just dangerous. It was too much. So that was causing the reaction in the spinal cord, which was people were going paralyzed. So basically he felt that it wasn't so much the drug was a dangerous drug, but that it was being used inappropriately by some doctors at high levels to get better results than they were supposed to be using.
We have a next question from Jean Knapp on Facebook.
Hello, Gene.
When you started the surgery, you mentioned the herniation in the first disc was very large, so you inserted the tube very easily. Does the large size of the herniation mean it will take longer for the opening in the disc close after the operation?
Yes, that's a great question. Yes, so great question. The question was, because the herniation is so big, the tear is so big, is it going to take longer for the disc to heal? The answer is, I don't know. You know, it could, larger surface area could mean a longer time to heal. I don't know that for sure. I have no way to assess, you know, smaller herniation, bigger herniation, how long will it heal? I think healing has a lot to do with blood supply, which we know the disc does not have a good blood supply. It's very poor. That's why disc heals so slow. I think it also has to do with nutrition and nutrients and oxygenation. So the healthier the patient, the more nutrients they get in their diet, I think the faster it will heal. But it's a very good question. I just don't know 100% what the answer is.
The next question comes from Earth Body Official. does the dilator cause issues at the spot that it enters the disc? Found some studies saying that even a small needle can cause cell death and degeneration.
Yes, great question. So let's take a look at that. The question is, when you put the dilator in, doesn't that cause damage to the disc? You are correct. If I put the dilator into a normal disc, it would cause damage, probably some damage. But we're not putting the dilator in a normal disc. We're putting the dilator right into the herniation. So where we're going in with the dilator, the disc is already damaged severely. It doesn't cause any additional damage.
Okay, the next question comes from Earth Body Official again. Do you manually pulsate or mobilize the nerve root to help it wake back up?
No, we don't. The question is, when I'm down there operating next to the nerve root, do we do anything with the nerve root to make it wake up? The answer is no. You really want to leave the nerve roots alone and don't touch them. The more you touch them, the more likely they have damage. The nerves are very, very delicate. I tell people what they're most like is tofu, the very soft tofu. And you know, with tofu, if you pinch it just a little bit, you can actually cause a tear in the tofu. So we leave the nerve root alone. We just use a very gentle tube to push it aside, very gently, very minimally. That won't hurt the nerve. So there's nothing that I do to wake the nerve up. The nerve must wake up on its own. And the nerve will wake up on its own in different times for different people. So the time that it takes for the nerve to wake up on its own depends on how much damage there is to the nerve before surgery, how much damage is done to the nerve during surgery, if any, and how well the surgeon does the surgery in terms of decompressing the nerve root. So as long as the nerve is decompressed well, doesn't have too much damage before surgery, and the surgeon doesn't do any damage, then the nerve root should wake up usually within a few weeks or months. On the other hand, if there's long-standing compression of the nerve root for many, many months or years, the nerve root could take up to a year to wake up.
The next question's from, I would say it's a comment from Jane Ivy's Addiction on YouTube. I'm looking so forward to having my phone call for scheduling L3-4, L4-5, L5-S1.
Thank you very much for the comment. We are looking forward to helping you. L3-4, L4-5, L5-1, those are the three most common discs that we're fixing. We fixed them so much, and the patients are very happy with the results.
The next question is from Earth Body Official on YouTube. If there's that mild diffuse canal stenosis, does that mean there's a long annular tear?
Yes, great question. So if there's diffuse canal stenosis, does that mean there's a long annular tear? The answer is yes. That means that whenever you have stenosis, it's almost always from the disc herniation, and if it's diffuse and wide, that means the tear is wide and the herniation is wide.
The next question is from Earth Body Official again. Do you do a diagnostic test or CT scan before the procedure?
Yeah, so to make the right diagnosis for treating the proper discs for the surgery, we need to, number one, we need to have an MRI. Number two, I need to do a physical examination. And what I'm doing during the physical examination, I'm checking the patient's pain, and I ask the patient always, show me where your pain is the worst. And they will put their finger where they have the worst pain. And then I know where the discs are that are damaged. I want to make sure that where the patient has the pain, there's also on the MRI the herniated disc. Then I know based on the location of the pain that the disc that needs to be fixed with the surgery.
The next question is from Earth Body Official again. What do you think about percutaneous herniation removal?
What do I think about percutaneous herniation removal? Well, first of all, there's no specific treatment that is called percutaneous herniation removal. Percutaneous means procedure is done through the skin, and most of the time it refers to a needle-based procedure, something done with a needle. So if you were to ask me what do I think about just putting the needle and trying to take the herniation out through the needle, it will not work. You can see from the surgery the big pieces of herniation. They cannot come out through the needle. So percutaneous will not work. Now, I will tell you this. In other countries, such as Korea and China and India, the doctors use the word percutaneous to mean endoscopic. But in the United States, percutaneous is not the same as endoscopic. Percutaneous means it's done with a needle. You know, minimal incision, like needle incision. Okay, anything bigger than that is not percutaneous. So I think there's some, difference in the definition of percutaneous in different countries by different doctors. But percutaneous to me means done through the needle.
The next question's from Lalit Khatana on YouTube.
Hello, Lalit Khatana.
Hello doctor, thanks for sharing. I'm a professional dancer from India. Do you know any doctor performing laser disc surgery in India?
No, I don't know of any doctors in India performing it. I know that there are doctors in India that perform endoscopic surgery. And I know that there's one Indian surgeon who was watching my surgeries, and I believe his name is Dr. Ayush Sharma. Ayush Sharma, Sharma. I don't know if he's good, but he's watching my surgeries and my technique. The problem with the laser is that it's very expensive. It's over $100,000, $125,000 machine. So it's very difficult for doctors to get the laser because it's so expensive to buy. We have here at our center millions of dollars worth of equipment that is for purpose of doing these surgeries. So I just think that it's difficult to find somewhere in India where they have, the money that they spent on all the equipment and supplies that we have. If you have to go in India, there are doctors doing endoscopic surgery. You might find one that can do your surgery. But I will warn you, what we do here at Duke Spine is very different than other doctors. And the laser is the most important tool to eliminate the back pain. So if your symptoms are in your leg, then you can possibly get rid of the leg symptoms with the endoscopic surgery without the laser. However, if you want to get rid of back pain, you need to have the laser done. And that's what we do at Duke Spine. We have patients who travel from India to come here. I would recommend you try to come here to get your surgery done. You can also use our free MRI review, which Sanjay here will put the link so you can get a free MRI review with me. It doesn't matter if you come or not. It's not important. What matters is you can have 10 minutes and I'll tell you what I recommend for your treatment.
The next question is from Earth Body Official on YouTube. If you were to work with chiropractors who don't do cracking after this procedure on alignment issues that may have contributed to the bulging or annual tears, is that recommended?
Yes, I like chiropractors. We do refer our patients to chiropractors. Chiropractors are, for the most part, are good doctors as long as they stick to doing what they're supposed to do, which is, manipulation of joints and range of motion and strengthening the core muscles. I think chiropractors can be very helpful. I don't believe that the deformity you're talking about, the curvature deformity, I don't believe that that is the cause of a disc herniation. I believe that deformity is the result of a disc herniation. In other words, the first thing that happens is not deformity. The first thing that happens is trauma to the motion segment. If you want to know what is the motion segment in the spine is the vertebral body above and below, the disc, and then the facet joints in the back, okay? And that, if you watch the movement here, that's the motion segment. This, and the joints in between, okay? We call that one motion segment. If you look here, there's two motion segments. You have 3 vertebral bodies, 2 discs, 4 facets. That's 2 motion segments. I don't believe that deformity arises first. I think injury arises first, and then injury creates deformity. The exception to this is what's called juvenile idiopathic scoliosis, which occurs in children where their spines begin to twist at a young age. And I don't think that has anything to do with trauma. I think that that is a genetic condition, but it's very rare, fortunately. The vast majority of people out there with chronic back and neck pain and deformity they come from what's called degenerative scoliosis, which is a result of traumatic injury to the spine, to the disc, to the facets, which then cause what's called subsidence, where the bones will settle, but instead of straight, one side will settle like this, and that will cause a curvature to arise.
I think that's all the questions we had for the session.
I want to say thank you to my team. Sanjay did a great job on this broadcast, and I want to thank everybody for the questions. They were great questions. They gave us a chance to talk about things. Our last surgery for today is another patient with 2 discs in the lower back, L4-5, L5-S1, both of them damaged through trauma. He's having back pain. He is a professional truck driver, and we were talking, he said he's driven more than 2 million miles. He's only 39 years old, and he drives 3,000 miles a week. He loves driving, but his back is hurting too much. And so he came here to Duke Spine from, I don't remember where. He's originally from, I believe, Bulgaria. Now he's living in, I think, Indianapolis or Chicago. We'll find out. And he's here to get his back fixed. So we'll be doing that last surgery in about 30 minutes.